Good evening, everyone. Today is September 27th, and it's good to be back with you. It's been a couple weeks. Welcome to the virtual town hall, Living with Lupus and COVID-19 in our community. It's co-sponsored by the Lupus Foundation of America, Georgia chapter. We thank Terry Emond for everything that she does in terms of helping us each and every day before, during, and after the pandemic. Also thank my colleagues at Emory and especially the GOAL research team, as well as the Georgia Council for Lupus Education and Awareness with Chris Reed and Representative Kim Schofield and others. Just reminding you that what we're talking about today is very general and that you should always take your individual and specific medical questions to your healthcare provider. Well, globally, we have over 32 million cases and 987,000 deaths. And in the US, we have over 7 million cases and 200,000 deaths. India has really springboarded into second place and is followed by Brazil. And you see Russia has over 1 million cases. And then you have Colombia, Peru, Mexico to the south of us. And then Argentina, and then you see Spain as well. We'll talk about them in a minute. Here you see the usual suspects with the US and South America still very hot in terms of large numbers of new cases. South Africa and and Australia here have cooled down a bit. You see in Africa, it's gone really up to the north of the continent. But what has been striking the past couple of weeks is what's been in the news, and that's been the surge of cases in Europe. You can see here that really Spain and France are driving the second wave, but you're hearing a lot also of cases and potential restrictions in the UK, as well as going into the eastern part of Europe. Now, what's interesting here is that Madrid in Spain opened, had their peak in terms of the hospital admissions and deaths right along the same time and almost to the same degree as New York City. And you can see both regards to hospital admissions and deaths, they had a high spike in the springtime and they both went down. What the difference is really with Spain and Madrid in particular here is that Madrid opened restaurants and bars on June 8th. New York City still doesn't allow indoor dining, but they plan to open at least about 25% seating capacity on September 30th, I believe, so which is a couple days from now. So you can see that again, achieving a lot of reduction in the number of cases, hospital admissions, and deaths is great, but it quickly can turn the other way. And what we're seeing in Europe is a good example of that. And what we're in New York is a good example of what can happen to a place that is really high in numbers, gets control of it and keeps control of it, and how you go about doing that. This is a heat map of new cases in the US. And if you recall from previous weeks, it was really red in the Southeast area. And I'll point this out again later, but it's still not white, that's for sure. But what you do see is the hottest areas seem to have kind of moved a little bit beyond the Southeast and into the Midwest for sure, the Tennessee Valley, and the upper Midwest. But Georgia is still number 5 in terms of total number of cases at 311,000 plus, and deaths at over 6,800. Cases are increasing now throughout much of the US. You can see here that we had been going down nicely, and we're probably getting a bump after Labor Day. Um, and the deaths have plateaued, but you wonder, I mean, the deaths are always going to lag behind the cases, and you wonder what's going to happen in a few weeks from now. Right now, there are 18 states where the cases are high and staying high, about 3 states where the cases are high but going down, and 9 states where the cases are low but going up, and 23 states where the cases are low and staying low. But um, again, what over the past week, we're starting to see this spike here, and there's been an average of about 41,800 cases per day, which is an increase of 7% from the average 2 weeks ago. And again, that may be a bump from Labor Day and people going on vacations, but the other big concern is going into the fall and the winter time when there's not going to be as much ability to do social distancing and being outdoors. That's a time when respiratory viruses like the flu and again like COVID, that's when we see traditionally the big spike in cases. So everybody's bracing for the potential spike that may be coming, and a lot of the computer modeling, for what that's worth, is predicting um, big increases unless we're extremely vigilant about that. Some national news along the lines of vaccines. Johnson and Johnson has a single shot vaccine as opposed to most of the other trials that have been at least 2 shots. And their vaccine apparently does not require refrigeration. Some of the other vaccines require not just refrigeration, but freezing, like really low temperatures. And that obviously is going to cause some logistical issues where places will have to have the ability to get those supplies transported in a refrigerated or frozen fashion and stored locally until it's given, just increasing not just the cost, but the complexities and reducing how quickly and efficiently we can get the vaccine out when it does go out. So this vaccine, if it really does show to be effective and safe, to be a single shot, not requiring refrigeration, would be a huge plus. There's an additional company that has a vaccine that's going to be starting in the UK. With all of the concerns about the process of approving vaccines and how um, the politics can really push it and potentially cause vaccines not quite ready or completely safe to be pushed out into the public, the FDA drafted guidelines that really raises the bar of safety and efficacy that vaccines would have to meet um, the requirement to be put out early. And for things to be put out early for the sake of public health, there's a mechanism called Emergency Use Authorization, the EUA. And it's not a full-blown approval, but it gets things out if they meet or seem to be meeting the requirements. And it was felt to be in the best interest of the public health for things to be out there. And if you may remember, hydroxychloroquine or Plaquenil received emergency use authorization for the treatment of COVID very early. So that was a good example of how politics can really push something out when it really wasn't ready. And we ultimately found out that hydroxychloroquine or Plaquenil is not effective for the treatment of active COVID. But anyway, everybody's trying to reassure the public and certainly the companies and the government outside of the political area, the scientific parts of the government, including the FDA, the NIH, and CDC. The last thing they want to do is destroy the confidence in the public. Otherwise, it would be of no use. So politics continues to cast doubt on the process, and we'll continue to discuss this over the coming weeks as we get closer potentially to a vaccine coming out. But just know that there are a lot of smart people that are well-meaning that have people's health and safety first and foremost in mind, and they recognize that these concerns are out there in the public. And by the way, the companies themselves, they're not out to make a quick buck of in the short term if it's going to shoot them in the foot in the long term. So there are lots of money, billions of dollars at stake here. And for them to be pushed around by politicians to have something go out that ultimately proves to be more harmful than good is not a good business decision. And so that has something going for us as well. Some of you have may have read about the CDC posting and then removing on their website information stating that the COVID virus can spread through aerosols. It still can, but let me just put it into context here. Um, as I said, COVID is a respiratory virus, and it goes from one person to another primarily through the air in droplets coming from people's respiratory systems who are infected. So they'll cough, or they'll talk, or they'll sing, and droplets will go out into the air. Droplets, but what I mean by droplets are the larger sized ones, and these are bigger. And because they are bigger with gravity, they tend to drop faster. And the ones that are on the relatively smaller range of what most people call droplet size will go to a distance of about 6 feet or so, or 2 or 3 meters. And so that's what's behind this whole 6 feet for social distancing. It's trying to minimize the major source of transmission are these larger droplets, if you will, that come from infected people. But they do go on the ground for the most part. It's really these smaller ones that tend to hang in the air, what we call aerosol size droplets that can go farther distances as well. And these are uh, what I heard is, uh, I like this term. These are aerosols of opportunity, meaning that most people don't get infected through these really um, smaller droplets that stay in the air longer. Thank goodness. But where people do get in trouble with this is if you're in close quarters and there's a lot of these droplets around, uh, and you're not having any masking, that's when these droplets will certainly have a greater chance of infecting somebody. So you're talking about concerts, bars, especially gyms, where people are close, may not be good ventilation. Some people may not be wearing masks. So for the most part, if you are staying a few feet away from people and at least one person, hopefully both sides are wearing masks, it's very unlikely that you're going to have an issue. Here's the hotspots for Georgia. You can see it's throughout the state. We're not mostly white, but you do see less dark red. But you continue to see areas of red, especially in some of the rural areas, and the darker orange. So uh, Georgia as a whole is still, um, even though our numbers are going down, I want you to get the impression here is that it's still smoldering. It's still relatively hot. Less hot than before, but we're still hot. And so the good news, though, is that the numbers are going down in Georgia. You can see here the death rates tend to lag, even though there's a spike up here. We'll have to wait and see, but I suspect that they'll continue to go down as long as our numbers are going down, which is different from our neighbors in South Carolina and Alabama. So that's good. It's not anything to completely relax about, but I'm glad that things are going in the right direction in our immediate area anyway. So we continue to remain not in red, but we remain in this orange area with respect to at least this one website, COVID Act Now. When they look at a composite of these different parameters, when you look at daily new cases, we still continue to be relatively high. The infection rate is not perfect, but it's not extremely high either. We're doing better with testing overall, and thankfully, our hospitals have room. We're not being overloaded with cases. we're not doing great with tracers, but definitely better than before. So all in all, we are not at the highest, but we're actually at the second highest, and hopefully we'll continue to go down. And just to underscore what I said earlier, the hospitalizations in Georgia as a whole are going down. In Metro Atlanta, these are the people in the hospital totally, and all of the hospital in terms of positive COVID patients, and that's going down. And these are the people in the ICU, and that number is going down. But you know me, I don't like to be too optimistic because the tendency for people to be complacent. It's just human nature. And you know, when I say the Southeast is going down, you have to put that into perspective. So here's the South where we are, and the total number of cases going down. But look at where we are relative to where everybody else is. We are pretty much at the point of the highest peak out in the West. The West is going down too, but they're lower than we are. And what we're calling down is kind of up in the high area of where they were. What we're calling down is the peak of where the Midwest is, and they're on fire right now. But look where we were, and you know, it's all relative. It's good. Again, we should thank our neighbors for doing the right thing. Thank all of us. We're doing a good job. We are going down, but we're only at the highest peak where the Midwest is. And look where the Northeast was. They were the highest in the country. We were almost at their peak. They went down and they stayed down, and we're not even close to that. The agency published an article about withholding COVID-19 case counts from the public. How else can we find out what is going on in Georgia? You may be referencing this article where in the AJC it talks about how Georgia health officials have decided to withhold information about coronavirus infections at each school, saying that the public has no legal right to information about outbreaks that the state is investigating, which is really ludicrous. I hope you guys are just aghast at that and not having the ability to know what's going on locally, specifically at the schools where our children are attending. The question here is really, you know, it gives you a sense that you can't trust all the numbers, and that's not true. Uh, you know, there still is a standardized process to report overall numbers, and even though there's meddling from a political level to try to interfere with how that is reported and to whom. And, you know, generally speaking, you know, I think that has been okay. We have a lot of people watching those numbers. What this is talking about here, if the person asking the question is referencing this story, this is regarding the specific school specific numbers. And so that is being withheld. But the overall number is coming from different sites. And those sites, we all have to depend to a certain degree on the government numbers. But every site is looking at it slightly differently, double checking things to the best of their ability. And again, we do have to depend on the reporting system to some degree. And that seems to be generally intact. It's just, you know, certain specific situations like this that we have to keep informing each other about and being aware of. And so just know, unfortunately, it seems that the state is able to report school specific numbers, but is choosing not to. And unfortunately, that's also a phenomenon that's happening in other states from what I've been reading. I was fortunate enough to be part of an international lupus meeting that occurs every couple of years. It's predominantly for North American investigators, and it's been a wonderful time to be apprised of the up-to-date advances and to meet with other people in the field devoting their lives to learning and treating and researching lupus. This year we had to do it virtually. Had a really nice presentation from a variety of people, and what I thought I would do in the coming weeks is to just report on the summaries that I've heard, as well as any information that I can add to that, and give you kind of the state of the art in terms of the research that we know it. Um, each week or every other week when we do this, I'll have a different aspect of what was presented. The first question, and this is from a talk by Dr. Junus Yazdani, who did a nice job. She's an investigator at University of California, San Francisco, who looked at the scientific literature and summarized it. But one of the questions that she's addressing with the summary was, are people on immunosuppressive medications at significantly higher risk of being infected by COVID? So this isn't necessarily lupus specific, but obviously one of the things that many of us worry about is that when you are on medications that many people are on for the treatment of lupus, it suppresses their immune system. And could that be a factor for increasing infection rates? And by the way, one of the themes that generally came out of this meeting with regards to COVID, it wasn't all about COVID, but there were a few talks. And the good news out of all of this is that there wasn't the initial fear that we all had was, again, this concept that if you have an autoimmune disease, you're on immunosuppressive medications, the fear is that the rates would be much higher and the complications would be much higher, but it generally hasn't been the case. So I'll give you the overall punchline in the coming weeks, but we'll fill in the details, and obviously there's some caveats along the way. But when we talk about general risk of people that are immunosuppressed for COVID, this is one study that came out very early in the COVID. It's in the northern part of Italy called Lombardy region, and they did a survey of rheumatology patients, almost 1,000 patients, 995, and it was 98% of their list basically. So they had a really good response rate. Almost essentially everybody that had a rheumatic disease in that region responded to the survey, and they asked about infections and so forth. And so it confirmed that basically the overall rate of infections in people with rheumatic diseases on medications to lower their immune system was essentially the same as the general population. I mean, it was a touch lower on the percentage side, but statistically, it's probably equal. So that was the initial study that came out very early. Again, it's not the US, but it was in a region that was terribly hit very early on. Now, this is out of Hong Kong, where they were able to utilize their healthcare system database, which covers essentially everybody in their country, the city anyway. And they had 1,067 cases of COVID diagnosed in Hong Kong, in the city of about 7.5 million people. And out of that, only 5 patients with rheumatic diseases developed COVID-19. And ultimately, the percentages were essentially equal within those with rheumatic disease and those in the general population in terms of the proportion of people who got infected. Again, different health system, different environment. But anyway, we didn't see huge rates in rheumatic disease across different countries, which was good. Now, here in the US, the National Veterans Administration, or VA database, was queried for information between January and April of 2020. They looked specifically at not rheumatic diseases, but people with inflammatory bowel disease. So with Crohn or ulcerative colitis are the 2 major ones in that category. So these are a form of autoimmune condition, but in the gut. And looking at 37,821 veterans with inflammatory bowel disease, there were only 36 cases of COVID. And one of the drugs used a lot in people with inflammatory bowel disease is in the class of anti-TNF medications like Humira and Enbrel. These are common drugs also in rheumatoid arthritis and psoriatic arthritis, as well as they looked at these users and other immunosuppressive medication users, and there was no increase in infection rates in these individuals. So the summary of the current research in terms of are people who are immunosuppressed on immune suppressing medications at high risk of getting infected? It seems that almost all studies show that these rates are very similar to the general population. Now, one caveat could be that people who are immunosuppressed are just more likely to follow COVID-19 precautions and be safer, and so therefore they're getting less infections. But be that as it may, it's good to know that being on these medications, even if you are a bit more careful, isn't putting you at much higher risk of getting infections. Perhaps other people would not have gotten infections, but a lupus person would have, given their immune suppressing medications. That's not the case. So that concern doesn't seem to be holding out in several studies in different areas, but large studies, and they all have the same results. So the risk of getting COVID seems to be from exposures, not from being immunocompromised per se. So here's a question. I'm a patient who's considering seeking medical care out of state, and the medical facilities in the southeast region, so you can travel by car. Do I have any general thoughts or precautions that this person could take to minimize the risk of contracting the virus? Plans to stop in public places and bathrooms during the trip. No additional new thoughts. Uh, you, if you've been listening to at least any few of the previous town halls, it's this broken record. As long as you you can maintain distance to the best of your ability, you mask, you wash your hands, um, that is going to minimize the risk. And there's just no way I can give a magic line of this is safe or this isn't safe. We all know by now that there are no such conclusions, but the safest you can make it, given traveling as you describe it, is just practicing what everybody should be practicing anyway. Here at the end, it says, could you give out the name of the mask I mentioned that's equivalent to the N95s? It's called the KN95. Um, and it's supposed to meet basically the standards of the N95, and the K for, I'm not sure why they made it a K, but it designates it's from overseas, and I believe it's specific to China, or most of the masks come from China. But in any case, I saw this article about a week or two ago, and it seems like a lot of these masks that are coming from China don't really exactly meet the the standards for what we in the US would call the N95 masks that the healthcare providers would use when they're caring for someone that's known to be infected with COVID. Now, let's put this in context, though. If you're a healthcare provider, this is important information because you need something that is going to protect you at the standard of an N95 mask. So if you're an individual that is a part of your job, and I can't think of anything off the top of my head outside of a healthcare provider that knowingly puts an individual directly in front of somebody who is infected with COVID, then the whole N95 standard is really overkill. Um, I think that most of the KN95s, like the other um, regular masks that you see out there, that all for people in the general public doing what you need to be doing, uh, going to the hospital, the pharmacy, running your errands, maintaining social distance the best that you can, and washing your hands, then N95 is a standard that is really way, way, way above what you need to be. And I suspect that most KN95 masks are going to be fine, because even if they don't meet the N95s, they're still going to be a higher standard than a bandana or just covering your mouth with your hands. So whatever you can get in terms of multiple layers that have a nice seal around your nose and mouth, whether it be a KN95 and N95, but honestly, the cloth masks that you see that are ties, that are multi-layered, that have good seals around them. That's what you need. But if you really want to go higher and you are in a work environment where you're around a lot of people, obviously you want to get the best that you can get. And N95 masks are not available to the general public. So I think even the fact that a lot of these overseas masks may not be completely N95, I'm sure they're going to be decent. But look into it on your own. Don't take what I'm saying as a general, green light for. I'm not endorsing any product. I'm just saying a mask is good, and we're telling you you can make a homemade mask. And so, I mean, these are far from N95 standards, and they're going to be good. Do you have any advice on whether a high-risk patient should visit a hair salon at this time? This person's familiar with a salon that's invested a lot with protective barriers, mandatory masks, health screening, and sanitizing. Would it be more advisable to try to find someone who would give a haircut in an outdoor environment? So more the better. And again, there it's impossible to draw a line saying you should do this and not do that. So the more you can do, the better. The less you can do, the more risk it'll be. And just know generally what we know and don't know, and everybody has to make their individual choices. But I will show you a slide that I showed a few weeks ago, and that is a study from the MMWR journal, which is a very highly cited journal from the CDC that publishes really relevant, high impactful public health um, types of findings. And here they report two hairstylists who were positive with COVID-19 and who were documented to have spent at least 15 minutes with 139 clients, but none of them were known to be infected. The clients, that is, even though the hairstylists that spent at least 15 minutes with them were eventually found to have been actively infected and infectious during the time that they cut these people's hairs. And that was because everyone wore face coverings. So it gives you the power of consistent masking and the impact that it can have. So, to go back to that question, I think this hair salon that you're pointing out is doing a lot, and especially if they're doing the mandatory masks with all individuals. Again, if you had all of that plus it was outdoors, you would be even safer. Uh, but just know that there's at least some examples of good masking and how it can protect people in a hair salon environment indoors. How could theories like the herd immunity impact COVID-19, and more specifically, people with lupus? Uh, think of herd immunity as one way of thinking about what herd immunity is that it's what we've been doing all along with the flu. The flu is out there, and it has been. It gets worse in the winter time, but we never really did too much other than the vaccines. People didn't wear masks like we're doing now because in the general population, about 50%, at least 50, I don't know the exact number, so don't hold me to it, but over 50% of the population would get vaccinated with the flu vaccine. And then the others were not at highest risk for some of the bad outcomes, like children, um, and and even the younger people and middle-aged people. You're really worried about the older people that got the flu. Those are the people that unfortunately passed away, and many people did pass away from flu. But it's just that um, uh, at least half of the population were vaccinated, so they were protected, and the others were not as dangerous in terms of the outcomes of if they were to get flu. So really about 70, 80, 90% of the population were either vaccinated or could get flu with relatively minimal risk. They decided to take the risk on themselves. So that's what we're trying to get at with COVID is we're trying to get to the point where there's enough vaccine or there's good vaccines and enough people to take them. And yes, some people who would get infections and then recover from them, but that's not the ideal way to do it because you don't know how sick you're going to get. But when you combine all of those, you want about 70% of the population to have that immunity. And what some of these, I'm just going to say it, these wackos that are on TV and social media, when they're kind of claiming we can get to herd immunity without doing anything, and basically kind of using that as an excuse to ignore the masking rules. And we're doing so well because we're getting herd immunity. That is absolutely false. Um, the big thing that came out with Anthony Fauci and his report to Congress, I- and there was a big sort of um, he kind of clashed with Senator Paul in this discussion, and Senator Paul was just sort of alluding to the fact that New York is doing well, and it seems to be doing well because everybody got herd immunity, and that's not true. New York City has about 20% immunity, and other places are going to be there or lower. And to get at herd immunity, where we just rip off all our masks, let the virus take its course, is going to have an absolute horrific impact to our population and the hospitals and the deaths. And to get to 70% plus is just absolutely impossible. So the only way to get there is, yes, I want herd immunity through a vaccine. And that's our hope. I've learned a lot in the last couple of weeks about cycle thresholds with the PCR test. Is this true? Is this true? This isn't a good test for COVID. I I don't know much about this cycle threshold. I'm not an expert in laboratory medicine. Um, so I'm sorry, I don't know how to answer that, and I don't want to give you anything. Even if I looked it up, it's not really in the realm of my comfort zone to talk about it. But the P, but I will point out is, what do you mean by test for COVID? That's one thing to consider. There are a lot of different tests, and we use it for different reasons. The PCR test generally is a good test, and for all intents and purposes, it's the gold standard for someone who may be actively infectious. It detects viral particles at small amounts very well, so well that people are positive much after the infectious period because it will pick up bits of virus that's left over after the initial infection, even though there are no active viral particles infecting the individual. And then there are other ways to do the test that we can use in other situations, like testing asymptomatic individuals or for screening people. Um, so that's a whole other topic that I'll kind of stay out of for now. But I'm sorry, I just can't answer that direct question. So I'm going to end by pointing out this coping with stress and anxiety during COVID-19 webinar that the Lupus Foundation Georgia chapter is helping to put together. You can see here the presenters at the bottom, and it's talking about what's so important is, in addition to the body, the mind, uh, especially in this time of not just the infection, but the stress and anxiety that goes along with it, and the isolation, and all of the other social impacts, um, working, family, children. It's an important thing. It's just as important, as you all know, um, as the actual medication part. So I hope you can make what sounds to be a very nice and relevant topic this Wednesday at 7 p.m. You can register by going to lupusga.org. And you can also go to lupusga.org for all your news and information, including the COVID resources. And please continue to send your questions to the info@lfaga.org email. We will see you, or I will see you, in 2 weeks. And please, until then, be safe and healthy. Thank you.